Immunoproliferative and immunodeficiency diseases. Immunoproliferative diseases are typically malignancies involving lymphoid cells. They include leukemias, like malignant cells in the bone marrow and peripheral blood, and lymphomas, or malignant cells arise in lymphoid tissue, such as the lymph nodes, tonsils, or spleen. Also, plasma cell disgraces, malignant or premalignant conditions of the plasma cells. The WHO classification is the most widely accepted system. This system is based on cell lineage, immunologic markers, genetic features, morphology, and cytochemical staining. Most of these diseases would be covered in a hematology course, so we're just going to briefly go through the main ones and what they're associated with. So acute lymphocytic leukemia, or ALL, is poorly differentiated lymphoid precursor cells, or blasts, in the bone marrow and peripheral blood. Chronic lymphocyte leukemia, or CLL, is most common leukemia in adults. It involves small, mature lymphocytes, almost always of B-cell origin, and it's positive for CD19 and weakly expresses CD20. Hairy cell leukemia, malignant lymphocytes with irregular cytoplasmic projections, mature B-cell neoplasm. Positive for CD19, 20, 22, and 103 is a highly specific marker. Hodgkin lymphoma, or HL. Hodgkin and Rheen-Sternberg cells in the lymph nodes and other lymphoid organs. Non-Hodgkin lymphoma, mostly in patients older than age 60 and associated with immunosuppression. Heterogeneous group of neoplasms, and most cases of B-cell origin, positive for surface Ig, CD19 or CD20, and rearranged Ig genes. Small lymphocytic lymphoma, follicular lymphomas, MALT lymphomas, diffuse large B-cell lymphoma, Burkitt lymphoma, mantle cell lymphoma, and lymphoblastic lymphoma. Some are T-cell or natural killer cell lymphomas. Plasma cell disgraces, disorders involving abnormal proliferation of the plasma cells, also known as monoclonal gammopathies, characterized by a clone of identical plasma cells and overproduction of a single immunoglobulin component, also known as an M protein or a paraprotein. Includes MGUS, multiple myeloma, Waldstrom macroglobulinemia, and heavy chain diseases. Monoclonal gammopathy of undetermined significance. It's a pre-malignant condition present in 3 to 4% of people older than age 50. Production of monoclonal low serum concentration less than 3 grams per deciliter, less than 10% bone marrow plasma cells, no clinical features of multiple myeloma. Approximately 1% of patients with MGUS will progress to multiple myeloma each year. Multiple myeloma is a malignancy of mature plasma cells. Plasma cells make up more than 10% of the bone marrow, CD38, 56, and 138 positive. There's lytic bone lesions and produce bone pain and hypercalcemia, or an increase of calcium in the blood. This shows a bone graft of multiple myeloma and the cells that you would see over here. Monoclonal IGs in multiple myeloma produced by a clone of malignant plasma cells present in serum and or urine. Monoclonal immunoglobulins, IgG is the most common, about 50% of cases. Sometimes we see IgA or the light chains only. In urine, they're called Bence-Jones proteins. IgM, D, and E are rare. Waldenstrom macroglobulinemia, malignant proliferation of IgM-producing B cells or plasma cells that infiltrate the bone marrow, spleen, and lymph nodes. also known as lymphoplasmacytic lymphoma, CD19, 20, 22, and 79A positive. Symptoms include fatigue, anemia, bleeding, plasma, hyperviscosity, and peripheral neuropathy. Monoclonal IgM in serum, Bence-Jones proteinuria in approximately 10% of cases, cryoglobulins in approximately 20% of patients, and cold agglutinins in some patients. Heavy chain diseases, rare B-cell lymphomas characterized by the production of free monoclonal heavy chains. Alpha heavy chain disease is the most common type. Gamma heavy chain disease is disseminated and localized forms. And mu heavy chain disease, most patients have a malignancy that resembles CLL. The laboratory evaluation of immunoproliferative diseases. Identification of the malignant cell population through CBC and differential with cytochemical staining. Immunophenotyping by flow cytometry. So we look at how many white blood cells are there, look at the quality and structure of the white blood cells and the maturity of the white blood cells. And then immunophenotyping, that's to detect those complex of differentiation, those CD markers on the surface of the cells, and that's accomplished through flow cytometry. We can also evaluate the immunoglobulins, the type, and the concentration. So serum immunoglobulin levels, serum protein electrophoresis, immunofixation electrophoresis in serum and urine, immunosubtraction, or serum-free light chains, and the assessment of gene and chromosome abnormalities, cytogenetics or molecular testing. So immunophenotyping by flow cytometry analyzes the cell surface marker expression. Samples are incubated with panels of fluorescent labeled antibody reagents specific for certain cell surface markers, and then it's examined by flow cytometry. It identifies a lineage of malignant cell population by its immunophenotype, or what's actually expressed on the surface. Abnormalities may be present, so you may have a gain or loss of antigen normally expressed by a cell type. Serum protein electrophoresis evaluates all of the different proteins that you would find in serum. Albumin is going to be the largest fraction of this, so you're going to see the largest peak for albumin. That is our primary protein that's going to allow for osmotic pressure in the blood, or albumin can transport different types of substances through the blood, so it's produced by the liver. It's extremely important. Then you have different fractions, alpha 1, alpha 2, beta, and then the gamma region. And the gamma region is where you would have those immunoglobulins. And in a normal patient, if you look at this one here, albumin should be the biggest, and then you should have some of these, and your gamma fraction should be wide but small. In here, you have polyclonal gammopathy. So you have a lot of different types of antibodies that are increased. In here, you have monoclonal gammopathy, where just one type of antibody is increased. Then there's immunofixation electrophoresis, where we have anti-IgG antibodies, anti-IgA, anti-IgM antibodies, anti-kappa or lambda units associated with this. And then we have a protein fixative. So this can actually take it a step further. So you would add the anti-sera, and then you would put the patient sample on there and let it run by electrophoresis, and you can see where they land and how dense those bands are. So in this, you have normal. Here, this is abnormal. So you can see the difference between these two. Immunosubtraction immunotyping. This technique uses capillary electrophoresis to identify monoclonal Ig. Anti-sera is added to the patient's serum. Binding of anti-sera to the patient's monoclonal Ig components changes the electrophoretic mobility. Monoclonal peaks disappear. So here you can see kappa or IgG. Serum-free light chain analysis is an automated latex-enhanced immunoassay. It measures free kappa and lambda light chain concentrations in serum, and then you calculate the ratio. Presence of malignant plasma cell clone is indicated by an abnormal ratio and increased K or lambda. There's also cytogenetics. Traditional karyotyping and FISH are used to identify chromosome abnormalities. In FISH, fluorescent tagged probes bind to complementary DNA sequences. So FISH stands for fluorescence in situ hybridization, and we'll learn more about that when we get to molecular diagnostics. Here's a picture of it. Molecular testing is more sensitive than cytogenetics, and most of the time this is done through PCR. We will amplify particular regions and then run them out on the gel. And you can review this summary as we go on to immunodeficiencies. So immunodeficiencies means that the immune system is not functioning properly. So they're disorders in which part of the immune system is missing or it's dysfunctional. There's a decreased ability to defend yourself against infections, and you're more susceptible to developing cancer. There's primary and secondary immunodeficiencies. Primary immunodeficiencies are inherited, so you're born with them. They could be X-linked, autosomal recessive, or autosomal dominant. Secondary immunodeficiencies are acquired as a result of conditions or are picked up throughout your lifetime. So you could get an infection like human immunodeficiency virus, which causes acquired immunodeficiency syndrome, or AIDS, autoimmune diseases, malignancy, or immunosuppressive therapy. Exposure to certain types of toxins and chemicals throughout your life can also decrease your immune system. Immune system components affected by PIDs, or primary immunodeficiencies. It could affect the humoral immunity. It's caused by defects in B cells or helper T cells. Patients are susceptible to bacterial infections, especially sinusitis and otitis media, or ear infections. Cell-mediated immunity involves T cell deficiencies. Patients are susceptible to intracellular pathogens such as viruses, fungi, some bacteria, and cancer. And then innate immunity. So neutrophils or macrophages could be impacted, which will predispose you to more bacterial infections, or complement bacterial infections and autoimmunity. There's 9 different categories of primary immunodeficiencies: combined immunodeficiency with associated or syndromic features, predominantly antibody deficiencies, diseases of immune dysregulation, congenital defects of phagocyte number, function, or both, defects in innate immunity, autoinflammatory disorders, complement deficiencies, and phenocopies of primary immunodeficiencies. So predominantly antibody deficiencies, low levels of Igs, also known as agamma-globulinemia, involve genetic defects in B cell maturation or defective interactions between B cells and T cells, may involve all Ig isotypes or just one subclass. Compare patient Ig levels with age-matched reference range. X-linked Bruton's tyrosine kinase deficiency arrested maturation at pre-B cell stage, so the B cells never fully mature. The lack of mature CD19 positive B cells in the blood and plasma cells in lymphoid tissues. This is treated with gamma globulins. Common variable immunodeficiency, heterogeneous group of disorders. It can be congenital or acquired. Symptoms begin at 10 to 20 years of age. Failure of B cells to mature into plasma cells as a result of B cell or helper T cell defects. And this is also treated with gamma globulins. This is a list of several others. So there's transient gamma globulinemia of infancy, selective IgA deficiency, IgG subclass deficiencies, or CD154 deficiency. Combined immunodeficiencies involve a T cell deficiency. The complex affect cell-mediated immunity and humoral immunity. Possible treatment would be bone marrow transplant to reconstitute immune function. So both cell-mediated and humoral immunity is impacted. Severe combined immunodeficiency disease, or SCID, is a group of very serious PIDs. All involve the defect in normal T cell development and may affect B cell and natural killer cell development depending on the type. Wiskott-Aldrich syndrome is a rare X-linked recessive PID. It's characterized by immunodeficiency, eczema, and thrombocytopenia, defective T cell function, and decreased IgM, but normal IgA and G, increased IgE. Defect in CD43, an integral membrane protein needed for signal transduction in lymphocytes. The DeGeorge anomaly, developmental abnormality in the third and fourth pharyngeal pouches in the embryo. Most patients have a deletion in chromosome 22. It results in the underdevelopment of the thymus and decrease in T cells, hypoparathyroidism, and hypocalcemia, cardiac abnormalities, mental retardation, and abnormal facial features. AT is a rare autosomal recessive syndrome. Ataxia is involuntary muscle movements. Telangiectasis is capillary swelling and red blotches on the skin. There's a low number of T cells and defective antibody responses. Involves the mutation on chromosome 11, resulting in defective DNA repair and gene rearrangement in T and B cells. Defect in phagocytic cell function, chronic granulomatous or granulomatous disease, CGD. It's a group of disorders inherited as X-linked recessive or autosomal recessive. Neutrophils are unable to generate an oxidative burst, so it decreases the killing of catalase-positive organisms. Laboratory detection would be the nitrobutyl tetrazoleum NBT test or DHR assay. Complement deficiencies, most are inherited as autosomal recessive. Deficiencies in early complement components associated with lupus-like syndrome. Deficiencies in complement components, in late complement components, are associated with Neisseria meningitidis infections. And deficiency in C1 esterase inhibitor causes hereditary neuroangioedema. Screening for suspected immunodeficiency, we would do a patient history, a complete blood cell and white blood cell differential, or a complete blood count with white blood cell differential to see how many of which type of white blood cells are present, serum levels of IgG, M, A, and IgG subclasses, isohemagglutinins, antibody response after vaccination, delayed hypersensitivity type skin reactions for cell-mediated immunity, CH50 assay for complement function, and DHR assay for neutrophil function. Confirmatory tests would be immunophenotyping and flow cytometry to determine the numbers of B cells, helper T cells, cytotoxic T cells, and NK cells. And this is a diagram of that. There's also genetic testing. Genetic testing may not capture everything. Evaluation of immunoglobulins is done by methods previously described. So I talked about serum protein electrophoresis, immunofixation electrophoresis. We can also have quantitative measurement by nephelometry or radial immunodiffusion. Newborn screening tests are done. So the heel is nicked with some type of lancet, and then it's pressed onto a card, and it's quantitated by PCR. reflects the number of T cells mandated by many states, and it's used to screen for T cell deficiencies such as SCID. And you can read through the summary.